care and utility expenses through green and healthy homes, hosted by the National Housing Conference and the Green and Healthy Homes Initiative. My name is Janet Viveris, and I'm a Senior Research Associate at NHC. Joining me on this webinar is Ruth Ann Norton, President and CEO of the Green and Healthy Homes Initiative. A dedicated advocate for healthy housing, Ruth Ann broadened the mission of the organization, formerly the Coalition to End Childhood Lead Poisoning, by designing a groundbreaking national program built on a framework of cross-sector collaboration to deliver efficient, green, healthy, and safe homes in communities throughout the U.S. In just a moment, Ruth Ann will introduce her fellow panelists. Before I hand over the reins, I would like to thank Capital One for sponsoring NHC's Solution Webinar Week series. Any opinions or errors in this webinar, however, are ours and the authors alone. This webinar is part of the Solutions Webinar Week hosted by NHC, a series of webinars meant to showcase the depth of expertise, the range of perspectives, and the quality of information you can expect if you attend our Solutions 2014 conference. Solutions is NHC's national conference on state and local housing policy. Traveling to Oakland, California next month for this year's conference, and we've got a great lineup of 36 workshops, bonus sessions, and roundtables, 4 great mobile workshops all around the Bay Area, and plenty of opportunities for you to network with people from across the spectrum of affordable housing, from development to finance, to management, to policy, and research. I encourage you to visit www.nhc.org/solutions to learn more about the conference and to learn how to register. Just a few more final notes. First, I want to cover our most frequently asked question on our webinars, and that is this webinar being recorded? The answer is yes. An archived copy of this webinar will be made available to everyone who registered. We will send out a link to everyone once the recording is online, usually within a day or two. Second, please note that all participant lines are muted in order to ensure clear sound quality for everyone. However, we will be taking questions at the end of this webinar. If you have a question at any time during the webinar, please submit it through the question box in the GoToWebinar control panel. That's the box I've outlined in red here in this screenshot. We'll answer as many of your questions as possible at the end of the webinar. Finally, let's address technical difficulties. While we hope the webinar runs smoothly for everyone, we know this doesn't always happen. If you run into technical difficulties during the webinar, please use the Help menu at the top of the GoToWebinar control panel to locate technical support. If that does not work, please go to the GoToWebinar support website, support.citrixonline.com. And now I'm going to hand over the presentation to Ruth Ann.
Okay, thank you very much. And let me see if I've got the control I need, which I think I do. I want to thank the National Housing Conference very much for hosting us this afternoon to talk about our collaborative model to make housing in the United States healthier, safer, and more energy efficient. And I want to thank my co-panelists who will join here with me, David Salkever, who's a renowned health economist at the University of Maryland, Baltimore County at the Hilltop Institute, and a co-principal investigator on HUD's Healthy Homes technical study looking at the GHHI model, who will then be followed by Bruce Tun, who is a well-known researcher from Oak Ridge National Labs, and 3 Cubed, an innovative nonprofit doing research and evaluation around weatherization and energy. So thank you very much, and let me make sure I can advance my slides here. As we know, and as many know on this call, healthy housing has become an imperative in the United States if we are looking at the health, economic, and social outcomes of families in the U.S. And at the core of this is the task ahead of us. There are 9 million families who live in unhealthy housing that are burdening families through the high impact and negative impacts of health and environmental health hazards such as lead poisoning and asthma and trip and fall injury. And as you can see by this slide, our taxpayers are burdened by over $20 billion a year in avoidable costs for asthma-related illnesses from their homes, $43 billion in lead poisoning, and over $19 billion from trip and fall injury. This all basically translates into important factors for outcomes for families. There are 14.4 million school days missed every year in the United States, undermining a child's ability to, just from asthma, undermining their ability to learn, and lead poisoning undermining their ability to read. And all of that, when parents are caring for sick children, translates into 14 million missed work days a year. Included in this is the destabilization and the wealth depletion that comes from low-income families having over 20% of their income spent on energy every year, as compared to 4% for the average household in the United States. So GHHI started to look at this as the more it began to do actual work around health and energy in combination in houses. And what we found in our families is that on average they would have to miss 23 days of work just to chase the myriad of programs that were needed to address the environmental and energy impacts in their home. Programs from the federal, state, and local governments with differing qualifications, different programs from philanthropy and the private sector, all causing a very fractured system and most often failure, so families would remain stuck in unhealthy housing. So we wanted a different solution for families and for outcomes. And so we brought that by aligning and grading and coordinating work around the housing resources that were currently available at local governments, doing a resource and gap analysis to look at what could be remanaged and repurposed today to work together, and then to identify those needs that were not met through private sector support, through philanthropic support, but to bring it all together in one intake system so that there would be no wrong door of entry of families seeking weatherization, lead poisoning prevention, asthma control, families entering the offering their homes for foster care, they have roof repair needs. All of those families now, under the Green and Healthy Homes Initiative system throughout our cities, are taken in through a single intake system. And then we utilize across government and nonprofit partners a comprehensive assessment that looks at the behavioral impacts and the structural impacts of health and energy and safety. And in doing this, we're able to have a coordinated and integrated service approach so that workers that previously worked only on weatherization or lead or home repair issues are now cross-trained. And as you'll see in some of our later slides, cross-trained in a way that makes the work more efficient for families with better outcomes and higher wages. This also allows us to collect and have a shared data system across agencies working in the same site, the same city, so that families don't have to continue to answer the same questions or be tossed from one agency to the other, but we can collect shared data, which also allows us to have a better job of the follow-up for families on health and economic and social outcomes beyond the intervention. In the intervention, we do a combination of lead hazard reduction and asthma trigger control, indoor air quality, moisture control, pest management, trip and fall injury, and of course the complete energy efficiency and weatherization work. And in that, we have the improved service delivery, moving from 23 days of missed time to less than 3. We have improved health outcomes with reduced ER visits and hospitalizations, reduced energy consumption, which most often translating in reduced costs, and that allows the family to stabilize in a healthy and safe home and reduces turnover rates in low-income communities. But it also translates into improved work and school attendance, benefiting the long-term outcomes. So as I said, this is built around aligning not only federal agencies, which has been aligned through an interagency work group on healthy housing that works closely with GHHI and has produced a strategic plan promoting the integration of work around green, healthy, and safe housing. But it also teaches localities how to braid funding together in proper manners, to be able to do the proper reporting, but to leverage out the maximum outcomes. And it allows now for the increased use of social impact financing, and as we're building to the future of social innovation bonds. And these coordinated actions have a benefit on families as we are outlining. But the best way to do this is to tell you the story of one of our thousands of families that have been served by the Green and Healthy Homes Initiative. On the screen you see Dwayne Davis, at the time was a young 8-year-old who was repetitively hospitalized by asthma because of an unhealthy and energy efficient home. We were contacted by his mom, Laquan Young, because she was about to lose her job as an administrative assistant to our chief of police, Fred Bielfeld, in Baltimore City, because she was missing so much time caring for Dwayne and unable to care for her home and unable to get to work, that even with good performance at work, she was at risk of losing her home, a home that had allergens and old carpets and mold hazards caused by water leaks, a home where the air was leaking, there was poor energy inefficient, the broken mechanicals, bad gutters, and lots of chipping, peeling, and flaking paint. This is a job that normally would have about 8 different grant programs that Mrs. Young would have to utilize in order to address her home. She applied for weatherization and was turned down because of the lead hazard. She applied for lead poisoning hazard control and was turned down because of the moisture issues. She found GHHI, and instead we went in through a comprehensive assessment, looking at all of these issues and coordinating the funding available through 6 agencies, and allowed us to not have multiple appointments, but to very efficiently address the issues in Mrs. Young's home and better document what was going on as we aligned and leveraged the resources. We went and did an integrated approach, looking at everything from weatherization through mold remediation, and braided those funds to be able to reduce the cost of the entire program. So what did we find there? We found through braiding these resources that we were able to spend 25% less than the government would have spent otherwise. We were able to accomplish addressing all of those environmental health hazards, plus putting a cool roof on the home and adding new mechanicals at $12,000 versus the $16,000 that it would have cost for Mrs. Young to go individually on these programs. And we also saved an enormous amount of time. But coupled into this work and into all of that what we do in the Green and Healthy Homes Initiative is a very strong integration of education from intake all the way through with a 3, 6, 9, and 12-month follow-up post-intervention, and then annual follow-ups thereafter. That education allows us to work with families to adapt new behaviors, new maintenance approaches, and to be able to sustain the investments that we do structurally. So the family has new flooring, new mechanicals, new windows, but the most important thing that we should know about this family is that 5 years later, Dwayne has never returned to the emergency department. He has never returned to the hospital. He is on the honor roll at school, and Mrs. Young, instead of losing her job, has now been able to pursue her career as a detective in the Baltimore City Police Department, where she's now able to have a 401k account and a 529 college savings account, a family that is thriving and stable in their home. The other great aspect that Mrs. Young brought to this is she became an advocate in her community, and we've been able to do multiple homes within her own block to address children with asthma and families that were beset by these problems and having very similar outcomes. So GHHI is working nationally through a number of cities, as you see on this map, those in green and orange, where we are at work to work with cities to attain a Green and Healthy Homes Initiative designation. which means that there is a learning network that has signed a compact with the mayor and the local philanthropic leads, the leading housing and health agencies, all working together in this shared integrated work. And GHHI's work is able to help deliver more efficiently these government services that are necessary to improve the stock of healthy, safe, and energy-efficient housing. But what you'll also see in this map are all of the yellow dots where we have cities that have reached out, cities, counties, and states that have reached out to us seeking designation to work within these principles, which have also been this year adopted into the HUD Notice of Funds Availability, because they work and because on the ground outcomes for families are delivered. In the first 5,000 housing units that we did through 2012 with the 2013 with Green and Healthy Homes, we had over $70 million in philanthropic and private sector support to help lift up data systems and to put on the ground outcome brokers. Those are our individuals who are driving the platform of collaboration between agencies to ensure that the work is being done together and that proper data is being collected. We've seen great energy consumption reductions with families saving between $400 to $700 a year in energy. Bruce will talk more about that. Government programs that are saving 20 to 25% in upfront costs, and we've trained more than 1,100 individuals in green and healthy homes training that was helped to be developed by Cornell University and CEO, the Workforce Development Group out of New York. Their work was studied and showed that workers that are using this integrated approach of adding health and safety to their lead and weatherization training had a $4,000 to $8,000 a year increase in wages. And we've had improved asthma control. We've had a 60+% reduction in hospitalizations and an improved school attendance at 62% improvement to perfect attendance from kids who were previously missing school frequently or chronically, and an 88% increase in work attendance by parents through that improvement. So let me show you some of the data slides with the snapshots of the work that we've seen here. This graphic is showing you in a one-year snapshot that we took where in the beginning we had 52% of our families who had not had in the previous 6 months a visit to the ER, but we had 13% of the families who had 2 times, and 9% of our families with more than 4 times in the previous 6 months going to the emergency room for asthma. At the end of 12 months, after Green and Healthy Homes Initiative work, looking comprehensively at these environmental impacts, 86% of our families did not have a return visit to the emergency department, and the multiple visits were also down in significant numbers. There was a real impact on emergency room visits. We had a similar impact on hospitalizations. At the beginning of this period, 82% of the families had not had an incident of having their child in the hospital for asthma, which can be 3 to 5 days in length. But at the end of 12 months, that increased to 96% of families not having a child enduring hospitalization, and shrinking all of the other numbers, as you can see. This has a real material impact not only on the quality of life of families, that their children are able to sleep through the night, rest comfortably, not be in the hospital, but this is a big impact on Medicaid costs, on insurance costs, and out-of-pocket health care costs, where hospitalizations in Maryland can be up to $11,000 per $8,000 to $11,000 per hospitalization. We also had the same impact on missed school days. As you can see, that we had 28% of our children in this program not missing school ever because of asthma at the beginning of this 12-month period. At the end of the 12-month period, it was at 60%. At 9 months, we were at a little higher at 66%, but at the end of the year, we had 60% of our children not missing school due to asthma, the #1 reason not only in Baltimore, but nationally for kids to miss school. And I think I missed one, which is the missed work days slide here. Again, where we are seeing that the beginning of the 12-month period, 24% families were never missing because their child was having an episode of asthma. That increased to 64%, allowing families to go to work, earn an income, and be productive and moving their own lives and quality of life forward. So we see a real impact of this integration of health with our work around weatherization and around lead, where we're able to address issues like asthma. And not only are we able to improve quality of life and stabilization, kids being able to get to school, but we're able to better deliver these resources in a more efficient manner. When we began the Green and Healthy Homes Initiative, cities like Baltimore and Atlanta were having to defer or decline up to 60% of the families who applied for weatherization because of health and safety issues. Now that we are addressing those health and safety issues simultaneously, we're able to get the money where it needs to go, and families, children, and seniors are benefiting from this. This is just a snapshot of some of our partners who have helped to lift us up, and as we're moving forward in our work. If anybody on the line is interested to learn more about Green and Healthy Homes, to apply for designation or assistance through our program, please contact me at ranorton@ghhi.org. You're welcome to follow me on Twitter at RuthAnn Norton, or our organization at Healthy Housing. I'm going to turn this over to David Salkever, and he's going to talk more specifically around the study being led by UMBC's Hilltop Institute, looking at the benefits of green and healthy homes for in their work, which is also, we have on that program Johns Hopkins as well as UMBC. So David, I'll turn this over to you.
Thank you, Ruth Ann. By the way, since I'm audio only, since my computer didn't cooperate, just remind me quickly, I should take about 10 minutes, is that right?
Yes.
Okay, good. Let's see, can you all see the title slide for my brief presentation, Research Hypothesis for the UMBC GHHI Economic Study?
We can.
Up there? Good. I did notice, by the way, of course, right, the first thing I saw was that there's a misprint here because it's really hypotheses, a hypothesis, because there are several overall hypotheses we're looking at, and then we'll look at some of the specifics within them. I will say that the general approach that we're taking here in collaboration with the folks at GHHI and some other folks from Baltimore involved in this that I'll mention shortly, the general approach is to identify, ultimately we're going to hopefully recruit about 240 households in total into the study, all of whom will have the intervention, and then to the extent possible to compare their experiences before and after the intervention with the experiences of some sort of a control population or reference population. So in sort of economist lingo, what we're doing here is what might be called a difference in differences study. What we're interested in is how much of a difference do we see in the change from before to after in the households participating in the study, as opposed to the control or reference groups that we're looking at. So let me go to the next slide. One of the major aspects of impact of GHHI's work is in the area of use of medical services and cost. And our study is targeted very specifically on households that have children with asthma covered by Medicaid. And our general hypothesis is that the participation in the GHHI interventions will reduce the use of asthma-related health services for children with asthma covered by Medicaid. Now, I've listed on this slide 5 different categories of services or cost items that we are looking specifically at just to get a sense of how the numbers of these services or items was impacted by the GHHI initiative. So we're looking at asthma-related ER visits. We're looking at hospitalizations for acute asthma episodes. We're looking at ambulatory non-emergency medical visits for acute asthma episodes. We're looking at number of prescriptions for short-acting beta-agonist inhalers and number of prescriptions for oral corticosteroid bursts. And information on all of these items is coming from the Maryland Medicaid claims data. And Michael Abrams and the folks who we're working with at the Hilltop Institute, also housed at UMBC, they've been instrumental in setting up the process for pulling these data together. And when we look at the test of this general hypothesis in particular, we have for the Medicaid comparisons a matched control group that we are drawing from the Medicaid data itself. So here we are, for each household that is recruited into the study and has the intervention, we're selecting a comparison household based on the Medicaid data that we can use to match the characteristics in terms of medical comorbidities and use of medical services with the households that are in the GHHI study. In addition, if you go to the next slide, besides looking at cost, obviously there's also a strong interest in how much difference the intervention impact will have on, besides use, how much impact it will have on costs. And the idea here is pretty straightforward. We're looking at the same data source and basically looking at the changes in all medical services costs covered under Medicaid to see how did the change in those costs for the intervention households from baseline to follow-up compare with the change in those costs for our control population selected from outside of the group who are receiving the GHHI intervention. By the way, as a matter of study design, we're looking at a 1-year pre-intervention experience, and then we're looking at 12 months post-intervention experience for the measures of Medicaid covered use and cost of services. So this is really a major effort to actually take really a look at a broad spectrum of possible cost savings, including the items, the specific service items that I mentioned above, but also obviously the Medicaid data will let us look at other savings as well. If you go to the next slide, the general rubric here is we're now, in addition to looking at the medical use and cost savings, we're also looking at impacts on non-medical costs, some of which have already been discussed by Ruth Ann in terms of her description of prior work and ongoing activities of GHHI. One important component is school absences. And what we're doing here is, as part of the general study, after the intervention process has been started, GHHI will also be administering surveys. It has already done some of this because we're in process. They're administering follow-up surveys, 3 months, 6 months, 9 months, and 12 months to each of the households. And some of the information that we will be getting directly from the household surveys, information about school absences of the children in the household. In addition, we are getting information about the places where the study children have been attending school, and we're working with Baltimore Neighborhood Indicators Alliance, or BINIA for short, and those folks are compiling data more generally about trends in school absences, in particular schools and classrooms where these same children from the GHHI study will be enrolled. So for that hypothesis, for instance, of school absences, we don't have a direct individual control group, but we have the capability with BINIA's help of actually tracking at least the before and after experiences for the group of children who are in a similar school situation to the folks, the children in our study. A second type of non-medical cost that we're looking at is the utility costs for gas and electric. And in this case, we're relying upon a collaboration with Baltimore Gas Gas and Electric, the local utility, who is helping provide the information about the study households before and after gas and electric costs. And here again, we're working with them to develop a sort of reference comparison from other households who are not in the intervention study per se. We're not actually recruiting additional control households into the study for this purpose. We're again looking at comparable data on a group basis from outside of the study. The third item here is that the participation in the intervention will reduce days of work absences for parents and caregivers. That's coming directly from the surveys that the GHHI staff is doing with the households that are getting the intervention. And in this case, this one we're looking basically just at before and after, and we don't really have a separate reference group that we can compare the change to in this case, because we're not interviewing folks in any of the other households. If you go to the next slide, the one other general hypothesis that we're concerned about is whether the intensity level of the intervention makes a difference in terms of the observed impacts on the medical costs and the work absence days and the school days lost and the utility costs. And the reason for this interest is that with the help of the folks at GHHI, we've identified two different levels of intervention, a low intensity and a high intensity. And there are substantial differences in cost between those two interventions. So one of the things that we want to look at is, are the cost savings with the higher intensity intervention greater than the additional cost of the higher intensity intervention? Now, if you look at the next slide, you'll see a much more detailed listing of the low intensity intervention, and then the additional high intensity elements that are received by the tier 2 households. So you can see for basically all households, the intervention would include an integrated pest management, mattress and pillow covers, education. The education component is very important. Weatherization, HEPA filter-equipped vacuum, and indoor allergen reduction measures. That's a set of services interventions that all families in the study will receive. In addition, the Tier 2 folks will receive the next set of items that you see at the bottom of the slide, which involve often much more extensive structural problems that are being remedied, and that's obviously why there's going to be a major cost differences between the Tier 2 and the Tier 1 interventions. And our interest here is to see, is there also a savings difference that's involved as well. I think that pretty well covers what I want to say at this point. Obviously, we can come back with questions as we go along, but that's pretty much the general strategy for the study. And I guess one other advantage that we will have, of course, is when we look at our results, we'll also be able to look back and see how these square with some of the early experiences that Ruth Ann has already described to you. And we'll be able to do that in a fair amount of detail. So thanks, Ruth Ann, for getting me involved in the discussion today, and I'll be happy to answer questions when the time comes.
Thank you, Dr. Salkever. So, Dr. Ton, we'd like to have you join us now, Bruce, and talk about the health benefits of low-income weatherization and your great study that you have done across the country and your work in this area. Thank you.
Okay. Well, thank you, Ruth Ann. So I'm going to present the results, an overview of the results of a very comprehensive and rigorous evaluation that Oak Ridge National Laboratory is doing of Department of Energy's Weatherization Assistance Program.
Bruce, you there?
Yeah, I don't seem to have control over the slides.
Okay, let me...
You should have control if you give it a shot right now.
Okay. Oh, there we go. Okay. Our evaluations focused on energy savings, and we did a lot of work on trying to estimate the non-energy benefits of weatherization. And in my short presentation today, I'm going to focus on these 4 points. First, that weatherization is a cost-effective way to reduce energy consumption in low-income homes. And by virtue of all the measures that they put in homes, weatherization produces significant health and safety benefits as well. These benefits translate into immediate reductions in not only in energy costs, but also in healthcare costs. And it also improves the household's budget in other ways that I'll discuss. And I also want to mention that weatherization can contribute to local and state climate change mitigation and health-related adaptation efforts if you're thinking about a broader context for national housing types of programs. Okay, so a little bit about the weatherization program. So WAP, DOE provides grants to states and local weatherization agencies to weatherize low-income homes, and many of these agencies are also part of the GHHI network. Oak Ridge National Lab is leading the evaluation of WAP, and we've been working on this for, well, we started working on it a decade ago, and we've been actively collecting data and analyzing data for about 5 years now. We have collected data to estimate energy savings and non-energy benefits and cost effectiveness. We were able to estimate energy savings by home type, by single-family homes, mobile homes, small and large multifamily homes, fuel type, natural gas, electricity, fuel oil, propane, and by 5 climate zones, cold, very cold, moderate, and 2 hot climate zones. By way of example, the most common home that's weatherized in the United States heats with natural gas, single-family home, and on average, weatherization saves between 15 and 20% on their energy consumption. The savings are a little bit less in mobile homes because there's a little bit less you can do with mobile homes. And the large multifamily sector is quite interesting. We did a large study of about 100 buildings that are weatherized in New York City, for example. And the energy savings really depended on whether the building was centrally heated and central hot water, and whether it's heated with fuel oil, for example. But we have all those results, and Department of Energy expects us to be able to let the public know about all the results next month. So that's why I'm a little vague on my report this afternoon. So in looking at non-energy benefits, energy program evaluators have really focused on energy benefits of residential retrofit programs for a number of years. This figure is our take on how to understand the energy benefits. So whenever you spend $1 on weatherization, that dollar goes right into the economy and has macroeconomic benefits. That dollar leads to physical changes in the home. If you're reducing the use of fossil fuels either directly or reducing electricity consumption that's being produced by coal, for example, you have direct environmental benefits. Changing the home, reducing energy use in the home has direct income benefits. And also, as we'll talk about, health and safety benefits. So the DOE allows local weatherization agencies to spend up to 15% of their funds on health and safety. Plus there are co-benefits just from replacing furnaces and doing air sealing and so on. All of these benefits improve household well-being, and if the household's occupants are healthier, their medical costs are reduced, their out-of-pocket medical costs are reduced. They're able to pay for various things, and all of these things may actually ultimately benefit ratepayers. For example, if households are reducing the number of times that they're unable to pay for their utilities and reducing cutoffs and so on. This figure is a little bit more detail on the household budget benefits. So as I mentioned, weatherization can reduce energy costs. Attempts to reduce hot water use results also in water cost savings. As I said, if you're you have a little bit more money in your budget, you're better able to pay your utility bills, and then you're actually able to reduce your costs for not paying your bills. We have found that households are less likely to use short-term high-interest loans such as pawn shops and car title loans after weatherization, so they save on that interest payment. And as Ruth Ann mentioned, the average respondent, the average weatherization respondent in our national survey missed fewer days at work, and since only 20% of those workers have sick leave, that is a direct income benefit. And we're also finding that if they're better able to have a bit more money, they're better able to pay for prescriptions, and people not taking their prescriptions is like a $250 billion hit to the national budget every year, so that's a major benefit. We surveyed about 1,400 households, half and half that had received weatherization and half in a control group. And from this survey of respondents, we found, as Ruth Ann has found in their surveys, that the average asthma symptoms are reduced. There's a reduction in thermal stress, so a reduction in hypothermia and hyperthermia, so visits to the emergency department and hospitalizations from that. The program installs carbon monoxide monitors, so there's a reduction in carbon monoxide poisoning. They do various things that can reduce home fires and reduce the economic cost of fires, so that's a huge benefit there. We find that our post-weatherization that our respondents are better able to get more sleep and more rest because the home is more comfortable, the temperature is more comfortable, and noise intrusion decreases after weatherization. And they also report that they have improved mental and physical health, better able to afford food for your kids and so on, does lead to reduced stress and better mental health. And all these things have a direct impact on reducing health care costs, out-of-pocket costs, and reduced medical office visits related to asthma and thermal stress, for example, in addition to reduced emergency department visits and hospitalizations, and even reduced deaths. So in program year 2008, WAP subsidized the weatherization of 100,000 homes, and in those 100,000 homes lived about 250,000 people. And we estimate that for that program year, it was about 10 reduced deaths, and EPA puts a value on saving a life at $7.5 million. So even that small number of people that were benefited from the program can translate into a very large economic benefit for the program when you add up all the numbers. This table presents some results from our survey. So for example, you can see that the number of respondents who reported having an asthma symptom within 3 months of when they were interviewed went from 71% to 54% post-weatherization. We see a drop in asthma emergency department visits and hospitalizations. We see a drop in medical attention from being too hot or too cold, and so that's related to hyperthermia and hypothermia. And these are small numbers, but again, if you're talking about a population of 250,000 people that were touched, those numbers and benefits add up pretty quickly. And you can see we asked them about the number of physical days that were not good in the previous month, and that dropped from 10 to 5. And the bad mental health days dropped from 7 to about 4. And days didn't get enough rest or sleep dropped from about 12 to 6. So lots of good data from our national survey indicating that there are health benefits for weatherization. These are some example costs that we're using when we have done a monetization of some healthcare benefits related to weatherization. Again, these results should be available to the public next month. But so, for example, if you were able to prevent 10 episodes of thermal stress related to hospitalization, that's a program saving of $54,000 across the country. And almost twice that if you're reducing incidence of hypothermia. So we're finding in our analysis is that if you look at the comprehensive look at the health benefits across households that could be benefited by weatherization, the numbers add up quite quickly, and you get a very good benefit to cost ratio result for that. We do like to point out that weatherization is one of those programs that has climate change mitigation and adaptation benefits. So the mitigation pathway is fairly straightforward. Weatherization reduces energy consumption. Reducing energy consumption of fossil fuels reduces carbon emissions. And it's also important to point out that reducing consumption of fossil fuels has these other benefits, reducing sulfur dioxide emissions, nitrogen oxide emissions, and particulate matter emissions. And our evaluation monetized the benefits of these emissions reductions as well. And adaptation, from a very personal point of view, if you weatherize a house, it will reduce exposure to thermal stress from heat and cold, and many people that actually end up in the hospital or even dying because of thermal stress they're exposed in their homes, and so working on their homes is a real focal point if you want to reduce that health problem. A better weatherized house, air-sealed house, and insulated house will retain heat and coolness longer during power outages. The weatherization program has adopted the ASHRAE 62.2 ventilation standards, and we firmly believe that improved ventilation will reduce moisture issues, which could be more of an impact if we have more extreme weather events and higher precipitation rates in certain periods of time in parts of the country. And if you air seal a house, this is a research question, but we do believe that air sealing will reduce infiltration of outdoor air pollutants, and we believe that a lot of these pollutants will actually, their emissions will increase because of climate change, certainly tropospheric ozone and particulate matter from forest fires. This map shows where forecasters believe that there will be more heat waves across the country because of climate change. You can see that covers most of the country, so it's a major issue, I believe, that weatherization can help address. And to summarize, our evaluations have found that there are significant health and safety benefits to weatherization, and that these benefits are immediate. At the monetary value, if you add up all the non-energy benefits and the energy benefits, you have a pretty healthy benefit-cost ratio for the weatherization program. And then finally, thinking as a broader context for weatherization, that it really can be an important component for state and local climate change adaptation and mitigation plans. And here's my contact information at 3 Cubed and Oak Ridge National Lab if you want to follow up with anything I've had to say and keep track when some reports might be available. Thank you.
Thank you very much. And Janet, I guess I'll turn this over on behalf of Dr. Salkeefer, Dr. Ton, and myself to you. If we have any questions, we would love to answer them or to talk about the interventions or what we're looking at.
Yes. Thank you all for submitting questions. It looks like we've got some great ones coming in. The first one is, can we get a fact sheet of the stats used in this webinar? And I will be sure to send everyone who attended and registered for the webinar the PowerPoint, so you can reference that. The next question we have is, just curious if Dwayne's family rented.
No, they are homeowners.
Okay.
But in our work, we it's about a 50-50 mix between very low and low income rental units and families and homeowners.
Thank you, Ruth Ann. The next question goes to you as well. The question is, has GHHI addressed or considered addressing secondhand smoke in multi-unit complexes by establishing complex-wide smoke-free policies?
Well, most of GHHI to date has been really implemented in scattered site single-family housing, where we do, as part of the intensive and reiterative education, environmental tobacco smoke education, working with families on primary, secondary, and tertiary smoke. In the areas where we work in multifamily, we are working to support not only HUD's smoke-free housing campaign and their work, but working with multifamily owners to have smoke-free policies in common areas and in the units. It is part of our standard to do that.
The next question to come in is there any grant money available to educate and train the extremely low and low-income household communities?
We are actually ourselves putting in to have a national set of national curriculum to be able to distribute that out, but there are resources to do that, and if anyone wants to contact us at 410-534-6447, and just ask for me. I will get you connected to people on our staff who can help you with that.
Thank you. We have another question regarding policies on smoking and secondhand smoke, but this one should go, I believe, to Bruce. And the question is, does the Weatherization Assistance Program include any education or assistance regarding smoking in the home? And if not, has this been considered?
It's not a major emphasis of the program as far as I know. And it may be talked about, but it's not something that I'm aware that they have really put an emphasis on.
And not funded by WAP as part of their health and safety.
That's true. Client education is not a reimbursable expense for weatherization.
Thank you. The next question we have is there any reason that the benefits to low-income homeowners through weatherization would be different for market-rate homeowners through home performance?
Yes, and Ruth Ann can help on this question as well. So we find that the typical WAP household is less healthy than the typical non-low-income home. They have a higher incidence of somebody in the home who's disabled and higher incidence of somebody who is elderly. Their household conditions, the home conditions are worse as far as pest infestations and mold and so on. So coming into the program, there's more room for benefit there. And on the flip side, I think it's our belief that the local weatherization programs and crews are better able to carry out comprehensive home energy audits and weatherization programs than you would see in the home performance arena.
I would echo that we are often starting at a much deeper deficit on the health and economic impacts of weatherization and healthy housing. And so you do see sort of a higher trajectory on the return on that investment. Although there are many middle-income homes that we work in that are beset by lead and asthma triggers, probably more than the energy efficiency triggers, where there's pretty dramatic room for improvement as well. But in general, Bruce's comments are correct.
Thank you. Ruth Ann, there's been a couple of requests that have come in to repeat your phone number that you cited before. If you could repeat the phone number a little bit slower so people could take it down.
Sure, and it's also on, I don't know if we can go back to one of the slides, but it's 410-534-6447. And my email is ranorton@GHHI.org. There you go. You got the slide.
Thank you. The next question is for you, Ruth Ann. Does GHHI also apply their work in mid-income communities?
We do not as a general rule, although some of our sites are looking at fee-for-service as part of the augment to how they help to reinvest in their work in low-income housing. But the Green and Healthy Homes Initiative itself is typically looking at very low and low-income housing and the repurposing, remanaging of those resources that exist and the investment there. But many of the same principles apply and are beneficial and have an opportunity for GHHI sites to utilize that for social enterprise to help augment their work.
Thank you. We did have someone who made a comment that some local utilities are also doing energy efficiency audits for low and mods as well, mostly senior targeted. So thank you, Paul, for that piece of information. We did have a question that came in about WAP and whether WAP documented the effect on pest management.
As part of our survey of households, we did ask about pest infestations, and there was a very significant decrease in infestations post-weatherization. I don't have those numbers at hand right now, but there was a decrease, yes.
Thank you. There's another question for you, Bruce. How are the asthma data results shown by Bruce created? Was it a survey of clients?
Yes.
Okay.
Survey of the head of household for households that received weatherization.
Thank you. We have another question that came in asking for elaboration on the slip and fall issue.
So this is really investment around avoidable trip and fall. Things, making sure that flooring is safe, that railing is safe, that we're have carpets that are tacked down properly where there are carpets, area carpets and the like, where there's proper grab bars where needed. These are fairly low cost measures with very high returns, where people, with a unsturdy or broken railing can lead to a lot of injuries. Obviously, we know the downfall of elderly who receive hip injuries. The costs are enormous and the mortality rates accelerate. So there has been a lot of study. Sarah Stanton at Johns Hopkins, in fact, had received a Center for Medicaid innovation grant around this work of trip and fall injury. It's one of the low-hanging fruit areas of small investment and large return, and we can certainly talk to people more about it, but there's lots of great documentation on that work.
Thank you. We had a question come in for Dr. Salkever. Dr. Salkever, is the study that you referenced complete and freely available to the public?
Well, it will be. Right now, it's still in a pretty early stage. We're still recruiting our households, and our projected time frame from the entire study is that about a little more than 2 years from now, the study should be complete. We'll certainly try to get some results out, more sooner than that. Though it's a bit of a challenge because basically the time, there's a lot of time involved in recruiting households for the study, so we're sort of scrunched up a little bit in time that we can devote to the analysis at this point. But that's the time frame, basically, that it was a 3-year effort starting last November.
Thank you. We have a question.
Obviously, anybody can email me, and or if you're interested in being kept on a list to be updated about products from the research, just send me a note at salkever@umbc.edu.
We had a question come in for Bruce. Bruce, what study did the 2008 examples come from, the potential monetary benefit slides?
Right. There's a medical expenditure consumption survey, MEX. So we took the data from those data from that survey.
Thank you.
And I can, if that person wants to email me, I can also send them the link to that database.
Thank you, Bruce. We did have someone who made a comment that some WAP programs are connecting clients to smoke-free housing resources. This is happening in Vermont and New Hampshire through an integrated e-referral system. So that's something for people to take a look at if they're interested in smoking cessation issues. We had a question, how will the WAP survey results be distributed?
They will be on an Oak Ridge website, weatherization.ornl.gov.
Thank you. Another question is, has there been a focus on radon mitigation and links to lung cancer?
Sorry, go ahead, Bruce, if you want to talk about that first.
Okay. Yes, we did do a national indoor environmental quality study relating studying the impacts of weatherization on several measures of indoor environmental quality, and radon was one of those measures. That's one of those reports that will be available next month, and I can talk more about it next month.
We're also looking at radon in a large way in our GHHI Salt Lake site, where they have a significant problem. And in fact, it was quite compelling at a recent meeting that I went up to a series of meetings around this work in Salt Lake, and I met a woman who had gone through lung cancer treatment that cost about $1.5 million, and the fix, and her lung cancer was identified to be caused by radon in her home, where she dug out a basement for renovation. The fix would have cost $1,500, and the medical cost and the impact on her life $1.5 million later was really compelling about the need to look at this work.
Thank you. We had a comment and question come in. The comment is that this individual is aware that in the state of Washington, home inspectors are being taught not to report the presence of mold and told they only need to report the presence of moisture-producing factors. And their question is, what can be done to influence various home inspector groups to report the presence of mold in areas where no one goes except for the inspector? There have been cases this person has observed where mold has not been reported even after home inspections.
Well, there's a lot of work with the Healthy Homes advocacy community around the country on this. I'd like to know more about it. I personally was not aware of this particular set of events, and certainly we'd be happy to work with them to connect them to a number of the advocacy groups around this work and to help them think about it. But this is the first time I'm hearing about this. Certainly others in my organization might know more about the Washington State piece. But if they want to contact us, we would help them think about a strategy on this. There's certainly lots around our standard, the standards put out by the Public Health APHA and Enterprise that may be helpful. And there's also work being done on the International Building Code around health-based housing that may be helpful to be influential in turning this around.
Thank you. We have another question for you, Ruthann. Does GHHI provide any of its programming through the U.S. Green Building Council or any of their chapters throughout the U.S. or have any type of partnership with them at all?
We do not have a formal partnership with them, have met with them here in Maryland, and know that they're doing a lot of good work around infusing health into I was just at Green Build. And we do not currently work through their chapters, but we actually just hired a vice president for business development and partnerships, and I will make sure to connect on that, but we currently do not, but are supportive of a lot of the GBC or Green Building Council work. And then my work on the Sustainability Commission here in Maryland, we align very closely with the Green Building Council work. Opportunity.
Thank you, Ruthann. I did just get the slide that was referenced by Dr. Salkever earlier in the presentation that we didn't have, so I've just posted it. And this slide describes in detail the Tier 1 unit interventions and the Tier 2 unit interventions that Dr. Salkever was describing earlier. So if you want to take a look at that and let us know if you have any questions. It looks like we do have a comment with reference to that Washington State example on home inspections. There was a comment that the Washington case may be to protect inspectors from possible litigation. There may be a clause added in the PNS which allows for a checkoff for a separate mold testing component to be done in a lab. So that's something to keep in mind. But it looks like we are all out of questions at this point. So if you do have any further questions, you can contact Ruth Ann or myself, and we can get you in touch with the other panelists. And I'd just like to thank you all for your attendance and thank our wonderful panelists for their presentations today. Thanks again to Capital One for its financial support of NHC Solutions Week webinars. If you thought this webinar was informative as I did, I hope that you'll visit our Solutions 2014 website at www.nhc.org/solutions and check out our lineup of great speakers and sessions. I hope to see you all in Oakland next month. Thank you again for joining us.
Thank you. See you in Oakland.
Okay, thank you.